Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel. I bet today I will have more questions than I will answer, but I still wanted to share some interesting stuff that I've been looking at recently. I've been preparing to discuss nerve entrapments of the peroneal nerves, the deep and the superficial peroneal nerves. And so I've gotten into my nerve entrapment books and then also going online and looking at research. And some interesting things popped out that I don't think I read previously in Dr. Trescott's book for peripheral nerve entrapments. In her chapter about the superficial peroneal nerve and its entrapments, there is a brief mention of a correlation with restless leg syndrome, the entrapment of the superficial peroneal nerve, which innervates the outer part of the low leg, like the shin area, and the dorsal part of the foot mostly. So when people have an entrapment, they're often caused by, often you'll see it at the fascia near the exit of the nerve before it goes into the foot. So it comes out of the peroneus brevis muscle where it's a motor nerve, and then it branches forward and will often get caught in the fascia in that area before it goes down into the foot. And then there's another area where it can get entrapped in front of the ankle. But since it's providing sensory signaling, apparently when there's a decrease in that afferent signaling, that you have an increase in restless leg syndrome in many people. And so I saw some research online about decompression of the peroneal nerves, especially the superficial peroneal nerve, and a decrease in restless leg syndrome. Apparently, they were looking at how many people have restless leg syndrome who have these foot neuropathies, and it's more than half. And so they started looking at doing things like nerve stimulators. So they, like a TENS unit on the tibialis anterior often. Apparently there's a new device coming out, or it may already be out. It's coming out either this year or it came out late last year, which is a common peroneal nerve stimulator, like a band that goes around the low leg right below the knee. And it'll send electric stimulation while you sleep to increase a little bit of motor signaling. So basically one of the studies was using a little device on the tibialis anterior, like a TENS unit, and it would just create enough stimulus that there was an afferent signal, like the person could feel a little bit of the motor nerve signaling the tibialis anterior, so the muscles firing a little bit gently, not enough to keep them awake, but enough that it would decrease their restless leg syndrome. So they see some sort of correlation between sensory input and restless leg, or increase of restless leg syndrome. So when people have less feeling in the low leg, they'll have more restless leg syndrome. So there's some new stim devices coming out for restless leg sufferers. And I thought that was really interesting. I had not seen that connection before. Um, I have attempted to treat restless leg syndrome just by treating the leg muscles, the low leg and the quad, but not with any sort of neurological scientific understanding of what I might be accomplishing. So when people have had an improvement, I've just been happy for them, but not really known why it was helping. And now I'm starting to look more into this, and I'm going to be a little bit more thorough in my questioning when someone tells me they have restless leg syndrome. Definitely want to look to see if there's any disruption in the sensory input from the low leg. So I thought that was really interesting and probably not something that you also have heard about. I don't, I haven't heard anyone talk about it. Maybe everyone else knows and I don't, and everyone just doesn't talk about it because they think everyone else knows. But um, but I think it's very interesting. I think it's worth looking at for people with restless leg syndrome. Um, I think the typical standard of care is to put them on something like gabapentin, just try to decrease the nerve signaling, um, which probably does help a lot of people. Um, but not everybody wants to be on medication all the time, especially just to sleep, you know? So maybe this is something that could help people to not have to be on medication for restless leg syndrome. Um, I don't know if I have anything else to say about it. I have I have some updates on patients that I've talked about before. The one I just talked about with the sort of ilioinguinal nerve pain, he's doing way better. I think he's had 3 treatments with me now. After the second, he stopped taking his oxycodone. He was in constant pain. I guess after he had a gallbladder removal, he had the constant side pain, the area between the ribs and the pelvis. And so I've been treating it as an ilioinguinal or iliohypogastric nerve entrapment in the abs. And it has been very helpful for him because instead of being in constant pain, he feels it mostly when he's exerting himself, like using his core muscles. So we're making progress. It's not there yet, but he feels so he's so happy that when he can relax, he's not in pain. He's just sitting, relaxing. He's not in pain anymore. And I've been working a lot with his neck and his back, and he's doing great. He's very, very happy with his progress. Because he was in a lot of pain. He still has problems walking. One leg is weaker and doesn't move as well. So we're still working on getting the psoas firing better, getting the quads, releasing the hamstrings, things like that. But he's feeling very optimistic. He's feeling very good. Um, my pudendal nerve patient that I've been working on, it's been such a rough situation because she feels like this is the only thing that helps her, but it's not been a relief that will last. She'll feel better at the end of the session, and then the pudendal symptoms come back. Mostly, she has like rectal spasms, sometimes burning on the inner thigh and the groin area. Um, it's hard for her to sit for any period of time, and then sometimes standing will create the problem. So I've been trying to treat it as a pudendal nerve entrapment, working on deep rotators, anything that could affect the sacrotuberous ligament that could be compressing the pudendal nerve. Um, and then I kind of went back to something I thought I had ruled out early on, which was the inferior cluneal nerve. I think when I tried to treat it, it didn't change anything. But at that time, I think she had way more other symptoms. It was hard to weed out because she really has a group of problems. She has lateral femoral cutaneous symptoms. She has the ilioinguinal iliohypogastric symptoms. She has pudendal symptoms, and she has had previously superior cluneal symptoms, like a lot of bad stuff from her back. Um, she's had multiple surgeries. They tried to implant a spinal stimulator, and that made her symptoms worse. They took the trial off. They I forget the last surgery they did. She had relief for like a day, and then a squirrel jumped up on her or something. It scared her, and she jumped, and she hasn't been good since. Like everything seized up, and so the interesting, exciting thing is that when I was seeing her yesterday, um, I had in the recent past I had tried to treat the low glute area with needles and electric stim to see if that decreased her symptoms, just as kind of diagnostic for the lower those inferior cluneal nerves, because they can also create pain in the rectum and inner thigh, low glute sort of thing. Um, and so I had been doing that. She said the last time I did that, she was in more pain the next day. But then she actually had some better moments during the week. So I decided, let's go back to the QL, the lower QL. Let's see if there is some area in the low QL that could be entrapping the cluneal nerves where they come out. Um, and sure enough, she had more trigger points that I had not previously found. Um, she's pretty large, so um, it was a. I think I probably wasn't using a 75 on her QL in the past. I was probably using a 50 millimeter needle to dry needle the lower QL. So I used a longer needle. I found really good trigger points right above the pelvis, right above the iliac crest of the pelvis on the side, the affected side, and then a little bit higher up and deeper, there was more. So I did that, and she said, all my rectal symptoms are gone right now. And that was the first. That was the first. Previous treatments had decreased the intensity and frequency. So it was like, if it was like a heartbeat pulse sort of spasm that she was always having, it would become slower and less intense when I would be treating. But this was the first time that it went away during treatment. So I feel like I'm onto something. I'm excited about it. We're going to see what she tells me when I see her next week. But if obviously, if it improves and continues to improve, I will be doing it a whole episode and explaining the whole long story. Unfortunately, when you have these sort of outlier nerve entrapments, there aren't many people to help you. And she actually, I told her I thought it was the inferior cluneal nerve that could possibly be this problem, not just the pudendal. Could be both. The reason I think it's both is because when she would lie on her back, she feels heaviness inside her like uterus area. She feels like the pelvic floor, like there's a brick inside her. I said, that sounds horrible. She said, yeah, I'm kind of used to it, but it feels like everything is pressing down. So I do feel like it's pudendal as well, but I think some of her rectal stuff may be coming from the inferior gluteal nerve, so cluneal nerve. So I'm hopeful. And I definitely, like I said, I'd do a whole episode if I finally solve this mystery. But she mentioned these things to her neurologist, and they said, "Oh, we don't do that. You'd have to go to Cleveland Clinic for that. So that's how rare this is, and that's how rare the skill set is, I think, for things like cluneal nerve entrapment or even the pudendal nerve. She had some intravaginal injections for pudendal nerve pain, and it didn't really help her. And she said, I don't know what else to do, but she said, I would try it again if, if there's even a chance that it could help, because it's just a miserable thing. She's been dealing with this for more than 2 years. So, I guess that's all there is for this week. I will definitely update you as I see more progress. Very interesting cases. So, okay. So that's it for this week. Have a great week.